Welcome to today's webinar hosted by GSI Health and the Brooklyn Health Home. I'm Lori Evans-Bernstein, President of GSI Health, and I'll be moderating today's event. The title of this webinar is A Health Home in Action, a case study with the Brooklyn Health Home. The Brooklyn Health Home was founded by Maimonides Medical Center in Brooklyn, New York. Maimonides is a premier academic medical center dedicated to fostering healthy communities in the borough of Brooklyn. Today, we are so privileged to be joined by four executives and leaders from Maimonides Medical Center and the Brooklyn Health Home. Dr. David Cohen, Chair, Department of Population Health and Executive Vice President for Clinical Affairs and Affiliations at Maimonides Medical Center. Dr. Karen Nelson, Vice Chair, Department of Population Health and Executive Director of the Brooklyn Health Home. Madeline Rivera, Chief of Clinical Integration, Department of Population Health, and Michael Carberry, Chief Information Officer, Department of Population Health, as well as Lee Jones, CEO of GSI Health. The team today is going to tell their story of the Brooklyn Health Home, a groundbreaking and multifaceted program expected to transform the delivery and payment system in Brooklyn, serving as a model for the state and nationwide. The agenda for today is to talk about background and goals of the program, clinical and care management models, health IT tools for care coordination and population health, payer-provider collaboration, which gets into financial sustainability, and then a question and answer section. Let's begin.
Thanks, Lori. So the prototype for the program that we're going to discuss really was developed in 2006 when we developed a co-located model of behavioral health services and primary care to try to coordinate those services for patients with severe mental illness. By locating teams of general internists and psychiatrists in one site, we assumed that we were going to have a major impact on their ultimate care. What we found, in fact, was a decrease in the use of wraparound services, but it wasn't until a nurse identified the fact that the two teams were functioning individually and not really communicating that we started to really establish a difference. And we did that by asking the teams to meet jointly every morning to plan the care for that mutual group of patients that they were managing. Once that occurred, we started to see a rapid change in both patient behavior and in outcomes. Patients began to keep preventive appointments. They began to get services that they really needed, made less use of the emergency department, and tended to be hospitalized less frequently. Those changes were durable over the years from 2006 to now, and really have resulted in a decline in emergency department use of 50% and of inpatient hospitalizations by 30%. What we determined as a result of that pilot was that it was really the interaction between the two teams of providers that really made the difference. It wasn't the physical co-location, but it was the communication. And it was at about that same time that we developed a health information exchange here in Brooklyn. And as a first use case, we decided to see if we could manage the care of patients with severe mental illness among multiple providers across the borough using health information exchange. To make sure that everyone received a coordinated care plan and that providers could really see real-time what one another were doing. Our initial funding came from New York State and through a HEAL grant, and we knew at that point in time how we would coordinate services and pay for the behavioral health and medical services. We didn't have a venue for funding the care management. When along came health home funding from the federal government through New York State, and we applied and became one of the first health homes in New York, which enabled us to really tie together the services that were being provided by Maimonides and by now a number of other providers throughout the borough of Brooklyn. As we developed plans for what we dubbed a mental health home to to provide these coordinated services. We had over 50 organizations join into this effort, and all are connected through this information technology platform that we developed. In 2012, we applied for and received a grant from the Center for Medicare and Medicaid Innovation, and that Innovation Award really let us target specifically a group of patients with severe mental illness in the southwest portion of Brooklyn, an area that covers about 800,000 people and about 25,000 patients with severe mental illness. Our reason for targeting this particular population is because the burden of illness and suffering is extraordinarily high. On average, these patients tend to die 25 years earlier than patients without severe mental illness, and that's due to, number one, their underlying diseases, but also comorbid diseases that generally attend poor health care and can be the consequence of therapies for their psychiatric conditions. This group of patients does not have good access in general and needs a wide variety of services that aren't generally available in one place. What this system enabled us to do was pull together resources from throughout the borough to deal with the multiple needs of this group of patients, both medical and social services, spanning everything from drug treatment services to the correctional health facilities to job training to housing. Our goals then were really to identify that full range of behavioral, medical, and social problems affecting this group of patients, make sure that there really was collaboration among the provider group and real-time information about what each was doing for the patient so that a consolidated and coordinated care plan could be developed, and then ultimately to drive measurable improvements both in patient outcomes, in their health care, and in the efficiency with which that care is delivered.
So the outcomes we developed were based on a series of metrics looking at both process and specific outcomes. We were looking at the process of care around communication. We identified what we felt were appropriate response times based on patient problems. We targeted a decrease in inpatient and emergency department utilization. The magnitude was really quite substantial. In our initial effort with the co-located model, we did see a decrease in inpatient hospitalizations of about 30% and a decrease in emergency department use of 50%. And as I said, that's remained durable, and that remains our target for this program. What we have attempted to do is transform care from reactive services to any patients who might present to proactive services for a population for which we've said we are going to be accountable for the total services. And we're in the process now of really shoring up an information technology infrastructure to help us with the management of that group of patients and the development of registries so that we can see how we are doing. So with that, I'm going to turn it over to Madeline, who is going to discuss, oh, no, I'm not. Sorry. It really is important that this entire program was developed in the context of a collaboration of not only acute care hospitals, but hospitals and the various community-based organizations that are necessary to provide services. We are currently receiving funding from the New York State Department of Health. We're receiving funding from managed care organizations, particularly those that serve Medicaid populations. The funds for care coordination flow into the health home, and funds for direct clinical services into the groups of network providers with which the health home has contractual relationships. The goal here is to make sure that all of the services really are fully integrated and that we no longer deal with silos for clinical services, wraparound social services, and care coordination function. That's all put together in the system that Madeline will now describe.
So in this slide, you will see a diagram of our model, and you will see that the member is in the center. And the core team members consist of the care manager, care navigator, primary care physician, psychiatrist, and therapist. On the outermost circle, you will see all the various organizations who provide services when needed by the patient are brought into the core team composition. So you will see the correctional facilities, you see social service agencies, home care agencies. We made a real effort to make sure that we've covered all the services that our members would need. Outside of the core team, you will see the GSI Health Coordinator. So our platform where our core team members and care managers and all the various providers who provide services to our members communicate through our dashboard, creating a single integrated care plan. Outside, you will see HealthX, our RIA, and the State Health Information Network of New York. That does feed the data to our platform, and Mike, in a little bit, will be going over that with everyone. The next slide outlines, as David said, some of the providers in our network. We have over 50 providers and truly growing. Some who provide care management services and some who are network providers who provide a service to our members and includes acute care hospitals as well. These are some of the clinical programs in which we are involved in or will be involved in that really takes into account the person as a whole in coordinating the behavioral, medical, and social needs of the members. We recently kicked off a critical time intervention team which really addresses the needs of the highest of utilizers. For example, those who have high readmission rates, those who have a first-time psychotic breakdown. We are currently involved in a collaborative care initiative, which is through the New York State Department of Health, and who really focuses on those patients with mild to moderate depression and coordinating the care between primary care and psychiatry while utilizing care managers as a critical team member. And then there are the behavioral health transitions to managed care, especially transition into HARPs, the Health and Recovery Plans, that are due to go live in January 2015 here in New York, where we're coordinating the care of a subset of the SMI population. But here, there really exists a collaborative effort between MCOs, acute care facilities, community-based organizations to provide this care. So what are some of the key standards of practice? So what we're saying is that each patient must have a care team. So again, the care navigator, the care manager, psychiatrist, primary care doc, and therapist. That there is a single integrated care plan that is created that outlines all the current issues that our members are experiencing, such as perhaps housing, perhaps domestic violence, perhaps they've had an admission and they need medication reconciliation. That after a hospitalization, either for medical or psychiatric reasons, there is an appointment that is set afterwards within 7 days for primary care and within 5 days for a psychiatric admission. And very important, part of our protocols for care managers is that care managers must visit with the patients within 2 business days during a hospitalization. This is key. They are involved in the development of the discharge plan in communication with the clinicians and the case management staff of the hospitals. Our members have access to same-day or next-day appointments, and that case conferences occur, particularly around events such as hospitalizations and ER visits. This just outlines the care team members, but if you see on your right-hand side, you'll see that it includes specialty physicians, home care nurses, residents, social workers, and you'll see that it includes NCO care managers. The NCO care managers have traditionally been in contact with members telephonically. They have information that is key to helping us in the health homes conduct outreach to our members. So who are the care managers and the care navigators? Our care managers have various backgrounds. They could have bachelor's degrees in health-related fields. They could be MSWs. They could be those care managers who have transitioned from intensive care management programs and have perhaps 5 years of experience in doing this work and coordinating the activities for our members. Our care managers are those folks who are really out in the community. They spend, I would say, more than half day in terms of coordinating services for members, ensuring that they have primary care doctors and psychiatrists, perhaps taking them to appointments, developing or having input into individual care plans and making sure that that happens, making sure that medication reconciliation is current. They receive alerts when members are in the ED or in the hospital, participating in care planning. They meet the member basically where they're at, and they visit the members at home as well. The care navigators are those folks who are high school grads with at least 3 years of work experience. They sit in front of the PC. We like to say they are our air traffic controllers. They provide a real support to the care managers. They remind our members of appointments or inquire as to why someone missed an appointment and help with transportation arrangements as well. Care team responsibilities, as I mentioned before, and this is critical to our success, is the development of a single integrated care plan, identifying all current issues. We look towards member engagement and having the member have input into their plan of care, that there is ongoing and continuous communication between all core team members, specialists, social service organizations. And that case conferences, as David said before, this has been really the secret to our success, that case conferences take place, that especially around events such as hospitalizations, ER visits, perhaps post-release from the jail or prison system. And that we monitor alerts such as appointments or event notifications, and manage patient consent. And we look forward to analyzing our data and developing a total course of care model. I'm going to turn it over to Mike, who is going to really talk about the technology and the glue that holds everything together.
Thanks, Madeline. So I'd like to start the technical section with sort of an overview of the architecture of the system. So on the right-hand side, you see a series of applications or apps. Think of your iPad or your iPhone metaphor where you have multiple applications. And what's interesting about these is that not only do they function technically within that environment, but they're also integrated at a data and process level, which we'll talk about in a little bit. In the middle of the slide, you'll see the two ways the applications are presented to the user. The monitor simply depicts any workstation, and then the iPad depicts that this application can actually be used because it is a web browser-based application, can be used on an iPad in a mobile setting. We have several care managers who actually use their iPad in the field, just a simple 3G air connection, and it works very well. Then on the left-hand side, the top left quadrant, you'll see the platform itself, GSI Health Coordinator. It basically is the technology and orchestration engine, not only for the applications themselves, but also for managing data, for managing the interaction of processes, and also for communicating with outside entities, such as you'll see in the bottom left, which is the Rio and the Shiny. So then in the bottom left, this is a little bit New York particular slide. The Shiny is the statewide health information network of New York. Think of it as a network of networks, meaning in New York State, we've had a number of RIOs, or regional health information organizations, that have been established and in operation for close to 10 years now. The Shiny is the next step where all these RIOs are brought together to actually be integrated either physically, as in some cases here downstate in New York City, or logically where we communicate with each other via standards-based messages. So that's the overall architecture. Let's talk about the applications on the right. Looking at the top right, a couple applications, enrollment and care team. These are basic administrative applications. The third is a coordinated care plan, which is kind of the heart of the entire system. That's where all care team members, not only the care managers and care navigators, but the PCP, the psychiatrist, the specialists, collaborate in essentially real time about a patient's care. Then we have alerts and messaging. Alerts are where either because an event notification has been passed from the REAL, which we'll talk about in a second, or because something significant has happened in the care plan regarding a patient's care, alerts are created and actually transmitted to users. The messaging app is an ONC direct compliant messaging app. Right now it's being used internally for internal users to communicate with each other, including clinical information. In the near future, we expect to, via the shiny HISP, H-I-S-P, to be able to communicate with anyone on the outside who can also engage in direct messaging. The last three applications are applications that we're rolling out now. One, patient engagement. Secondly, Population Manager. Population Manager is a reporting and analytics tool. We've used it now a couple of times to fulfill our reporting responsibilities to CMS under an Healthcare Innovation Award grant that we're currently operating. And then finally, Patient Summary and Care Book, which is a way for users of the system to see very conveniently the most important information, clinical information, for example, that we got from the shiny, or potentially information that's been created in the care plan itself. I'd like to talk, go ahead.
So the next slide is just meant to give a little more context about the platform. I'm sure everyone usually is very familiar with electronic health records, so this slide helps create a distinction between what electronic health records were designed for and what the care coordination solution is designed for. And as you can see from this slide, they're very different. And the key point here is that while they're different, they need to work together. And we spend a lot of time talking about how to integrate the workflow between the electronic health record, which was designed for, quote-unquote, inside the four walls, and was designed to have a very important detailed patient chart, as opposed to what we refer to as outside the four walls, which was the care coordination platform that's unifying the care team, being able to track the patient as they move through the delivery system, and be able to bring the most important issues to the care team throughout the patient's as the patient moves through the delivery system. So importantly, we like to build those bridges between the electronic health record. There's different workflow suggestions that are being implemented, whether there's an alert received in the electronic health record that notifies the care team member that this is a patient that's involved in a clinical program that needs care coordination, whether there's a universal checkbox within the electronic health record that indicates the coordinated care plan for this patient is in the care coordination solution. And, one additional thing to point out here is related to the very detailed patient chart in the electronic health record compared to the coordinated care plan within the care coordination system that all members of the care team can contribute to, in addition to a care coordination summary that's really taking all the detailed information from an electronic health record, from a continuity of care document, and really summarizing it to be the top line issues for our care team so that information is much more actionable. And that is, one of the key distinctions here. The next slide helps to further describe and give context for the activities that Mike was describing in the previous slide. And this connotes the care team and the patient in the middle, and really the goals through the care coordination platform of being able to unify patient data. And I just spoke about that example with all the masses of data that we're seeing through electronic health records in continuity of care documents, and how we unify that and make it much more actionable and intelligent for the care team members. Being able to unify patient alerts. So Mike referenced the connection to the Shiny in New York and connections to other HIEs and EHRs and other places, but being able to alert the care team in real time when an important event has happened, whether it's an ED admission, for example. Being able to have secure communication at all times among the care team. Again, Mike mentioned the secure messaging based on the ONC direct protocols, and this supporting referral management among the care team. Unifying the care plan, talked about the coordinated care plan, documenting medical, behavioral, and social issues, always dynamic, always viewable, and editable by the care team. Unifying reporting and metrics, and we're going to get into that a little more in the next few slides about the measures that we're currently reporting on, the methodology that we take, and then the ongoing work we're doing in the analytics and reporting area. And certainly being able to unify the task and workflow management in the spirit of improving and having a unified care coordination process. So the next slide also lays out and really tees up the importance of this architecture for population health and for analytics and reporting. So you see the care coordination applications, and we just spoke a lot about those. It's really, the platform is unifying these applications into a seamless workflow for care coordination, and then certainly the analytics and reporting capabilities, a data warehouse under the covers, health information exchange capabilities to really unify data into a seamless and accessible repository for all sorts of reporting. And here, this is really documenting the data flows to give further understanding of the architecture. So because of the HIE capabilities, being able to connect to any system that's important in the new care delivery and payment model. So being able to connect to health information exchanges like we do in New York, being able to connect to electronic health records on the back end to bring data into our warehouse to support the reporting, in addition to the claims data sources, both public payers, Medicare, and hopefully soon Medicaid, and other managed care organization data to bring that data together with the clinical data, with the hospital administrative data to really do the types of reporting that are needed for these new programs. And then making sure that data, again, populates the data warehouse, but also flows into the different care coordination applications as needed. So an assessment, a clinical assessment in the care plan application may require lab results. That's an example of pulling data into an assessment to see, to populate the fields as necessary. And then certainly being able to make sure the data from the platform also feeds the data warehouse and all the analytics and reporting capabilities. And that really sets the stage for the next few slides around the discussion of the current outcome measures, which I think David or Karen are going to go through, and then the methodology in the future, which Lee Jones is going to go through.
So we'll use these as just an example of the kind of outcome measures that we chose to follow, in particular for our Innovation Award. Some of this, as you can imagine, is we get through the electronic record, through the Shiny. So the BMI assessment, to the extent that that's done in the hospital or in the primary care provider, it can get pulled over into the data platform, so it doesn't need to get put in manually. But these are the sorts of things that we're looking for that are clinical outcomes. We're then looking for, of course, changes in our admission rates, ED visits, and then some of the admissions for ambulatory care sensitive conditions.
Okay, great. And then Lee was going to take us through the methodology that we followed for this initial set of outcome metrics.
Certainly. So if any of you in the listening audience have tried to do any of these outcome reporting exercises, you'll quickly discover some of the things that I'm going to point out here. It's good to start with understanding what you want to report, and that may be dictated, as it was here, by requirements from the program and from the state. And you then have to look at the data sources and the kinds of data that you are able to collect. And when we look at what we can collect, it will impose constraints on what we report. And likewise, when we look at what we report, it will impose requirements on what we need to collect. And so that interchange and ladder walk is what we went through, which took us to the next stage of how is it that we can resolve any conflicts that have arisen between those two things, what we're able to collect and what we desire to report. So what happened in actuality is there's a path that has to be crafted so that you can ultimately deliver all the things that you want and build a plan in order to have the corresponding data that will support it. And so we went through that process. We were able to pick and choose the appropriate measures that would give the information in order to run the program. And we were able to impose any process or workflow changes that needed to happen in order to collect the data, as well as entreat all of the various kinds of data sources, whether they were from payer sources or provider sources, from their internal systems or through the Health Information Exchange. We were able to coalesce all those things into the set of reports that were going to be most efficacious. And at the end, once we've gone through those steps to understand what data is available, what reports we are able to generate, then we need to see how that data manifests itself in the platform itself. And so it may be through a set of reports that have to be given to some authority, in this case through New York State and others. But there are also a number of ways that that same data, those same set of measures and outcomes can be used in the delivery of care and in the coordination of care. And so it may be evident through different applications on the dashboard, through other kinds of uses beyond static reports. And so all of that culminates in, the understanding what data we needed to store in the warehouse. And that entire process is an evolving process, and we anticipate that it's going to continue to change as the requirements for the program change and the program gets more mature. So when we look forward on the next slide, we're now that we've mastered the idea of what data we can control and what data we're going to leverage and how it's been supporting the required reporting, we can now go into some of these more advanced topics in the use of that data, whether it's adding additional reports that will help to measure and control the program, or to start to leverage the data in identification of gaps in care. And so we have a number of different kinds of things in the care plan and in assessments and soon to come in clinical decision support that will help us to identify various protocols that are appropriate. Then we need to make sure that the data is able to tell us how we're doing against those protocols, and that's sort of a next step. Risk stratification already happens through our platform, where the people who are forming care teams and registering patients into particular programs in a de facto way sort of assign them into the programs that are appropriate. We can further enhance that with data by looking at the risk of certain disease states or outcomes or the intensity that's needed in their management, and the data now will support that. Patient assignment, giving them over into the appropriate places so that they can be managed, and the predictive analytics to understand what patients are our focus is another set of things that we'll be exploring as we go forward now that we've gotten through the initial stages of how to report effectively.
I think it's also important to, as this program matures and develops, we've come to some new understandings of a need for further input into the care plan, and that is specifically from the patient, particularly with this patient population as we deal with a recovery model. Their ability to view data, view their care plan, and be able to interact real time with a full set of providers is absolutely key to their recovery, and so that is functionality that we are beginning to build now as well, which takes us to next steps in the clinical program.
Yeah, I'll start this. This is just part of the transformation that we're trying to undertake here is a lot of what we're building in this IT platform is a way to bring claims data with clinical data and care management and social service data, and so we want to try to develop a different relationship with payers that reflects the fact that a lot of the information that providers need at the point of care, they actually are going to be able to get through this platform and don't need the insurance companies to be a step above that. So we're trying to figure out a way that all of the resources that are now in insurance plans in care management services could get integrated effectively into our dashboard so that they could share information that they might have about patients based on claims that we don't yet have through either the RIO or through our information in the care plan, and that they could serve as sort of care navigators for us so that they could do a lot of that background sorting through information that includes, again, information from the insurance plans like claims data, as well as our clinical information, and that they could then also help integrate some of the reporting functions that we've had to do so that we don't need to report to the managed care organizations and then back to providers with information that is different for the two, that we could integrate all that reporting so that it's actually actionable information for us as we're taking care of patients on the ground. And then the insurance company.
Yeah, I think it's our strong sense, and there's some real evidence that the current funding streams are really not going to persist forever. I think the health home funding stream as a separate one is going to more likely be rolled into insurance products that are managed through the different managed care companies with which we contract currently. We really are looking at a transformation of the system and a new way of dealing with our payer partners, and that's really as partners. We have developed a pilot for this health and recovery plan, a HARP, in New York State, where we're beginning to work with payers, incorporating their care managers into our care management systems, providing them with access to our systems so that they can both function as part of the clinical delivery system and as an internal third-party administrator for the management of the shared enterprise. We're looking at doing that with other chronic illnesses as well, and developing systems where a shared savings pool is developed that can then be rechanneled back into the provider community to reorganize services as we would like them to appear in the future. I think the final issue for us to confront is, with the real transformation of the healthcare system, the labor force is an issue that we need to deal with as well. This provides us with a real opportunity to train individuals who may, in fact, be displaced from inpatient services into other settings that are more suitable for the real ongoing care of patients in the future.
Well, thank you. I know a lot of folks ended up joining a little bit late, so we'll be able to send this around, so in case you missed the beginning, you'll be able to hear it. But now we're going to turn to questions, and if you have a question, you can type it into the chat function from the WebEx, and then we'll take those questions and have a discussion with the group. So I actually need to pull up those. For the benefit of the discussion, and maybe we'll start with just a round robin from our esteemed panel. Oh, actually, there is a question. Here we go. Great. They're starting to come in. I don't know if you can hear the chimes, but one question is, are you limited by the lack of electronic health records in post-acute or long-term care facilities, home care facilities that are participating in the program?
Obviously, to the extent that we have electronic records to contribute information to all of these systems, it's helpful. But I think the beauty of what we're working on together with GSI is that it is web-based. And so even those organizations that are small or don't have electronic medical records are able to see what's happening real time in terms of a patient's care plan and to contribute to that through that web-based system.
And I would just add to that one of the other benefits is that the program can be up and running pretty quickly, 30 to 90 days, depending upon the implementation, accessing the system from an internet connection and a web browser, and not needing to do any integration work or have any dependency on other systems. And then we start a process of looking at the integration and what's required in that respect in terms of the type of electronic health records in the landscape, whether there's HIEs or not, and so forth. But that's feathered in parallel so that the programs can begin realizing value quickly with enrolling patients in programs, building care teams, having a coordinated care plan, being able to message each other, so on and so forth. What's been the biggest challenge in building your care management and provider network?
We've really built it around partnerships with community organizations. I'd say that this has not been historically one of healthcare's finest hours. Acute care community-based organizations and acute care hospitals have not really functioned well together, and so developing trust as a partnership took a lot of time and effort. Interestingly, once everyone understood that we were building a system together and that everybody's input really counted, we've had a great deal of ongoing participation by all of the community groups that Madeline showed you in the slide before. That's about 55 organizations all working together. But frankly, partnerships are tough and they are fragile, and they really do require a lot of attention to make sure that everyone feels that they are truly participants in this effort. We have, in fact, created a separate governance structure that is not dominated by acute care hospitals, but that is really quite inclusive of all of the types of organizations that are needed for this patient population.
Next question. Clearly, Maimonides and the Brooklyn Health Home have been leaders, not just in New York and across the country, in developing and implementing the health home model. What is your advice to states and programs that are just beginning?
Oh, be careful what you wish for. I think New York State was really under the gun when the program was rolled out, and the first wave of rollouts didn't happen as quickly as we all had hoped. And because of that, there were capacity issues. I think moving forward in time, there can be additional planning, make sure that all of the partnerships work, that there are not too many health homes functioning in one geographic area, and that the relationships are clearly identified between health homes and payers so that they're working collaboratively and not at odds. It took a little while to sort all of that out, but I think we've learned a number of lessons in that area, and it should be easier going from here on in.
Do you have you determined the next set of measures to support your outcomes and operations of the program?
So I think the interesting thing about this partnership has been that a lot of the clinical standards are developed from committee structure, where most of the participants, all participants can come, most come to many of these meetings. So I think that what we've done is participants, care management organizations in particular, identify issues and problems that the care managers face, a committee then takes that on and creates a clinical standard around that everybody agrees on. So it allows the clinical standards to evolve in a way that I think really directly meet the needs of the care management teams as they're starting to work with patients. So I don't think we know what's coming next, but I think we know that it's about the issues that the care managers are dealing with this complicated patient population.
Do you have clinical decision support or plans to implement it?
Yeah, we have working with a company called MedCPU, and they've defined a set of measures and process measures and outcome measures where the decision support engine behind the scenes will present alerts to users and their supervisors when certain parameters are being exceeded. For example, if we have an event notification that someone's been admitted to an emergency department or inpatient care and it's not a follow-up within 2 days, or 2 hours, there'll be an alert created. When someone is discharged, we want them to follow up with either PCP or psychiatrist, depending upon the situation, within 5 or 7 days. If that appointment isn't recorded, there'll be again an alert to the user and ultimately to the supervisor. So this is sort of the first delivery on clinical decision support in the platform. If you know clinical decision support, you know you can take these kinds of things and extend it throughout the application and even to reporting as well.
Right.
And the thing I want to just add one piece to that is that we're trying to create clinical standards that include social service issues. So the group had decided that if a care manager sees an eviction notice when they're dealing with a patient, they wanted the supervisors to be alerted about that because they decided that that was a serious enough issue that they didn't want that to fall through the cracks. So this clinical decision support can be more than just clinical outcomes as we know them.
Right, that's an important feature, the natural language processing aspect of the clinical decision support. And so rather than being solely reliant upon what's in structured data, this engine can actually look through text, if you will, and determine, is there a housing situation? Is there a risk of domestic violence? And then bring that to the attention of the appropriate user or supervisor.
And then those alerts will be delivered, those prompts, if there's been a deficiency in the clinical protocols that Madeline and Karen and their teams have established, really based on the health home model. When those alerts are not followed or when there's a deficiency, that's when the prompt will be given to the care team, and that prompt will be accessible through the CareBook application that's in the GSIL coordinator platform. And then the partner, as Mike mentioned, MedCPU, is really the clinical algorithm software, if you will, that'll be embedded within the platform. Another question, since payers and providers have different information needs and different concerns, are you going to make your reports different?
I think, again, as the payer and provider community come together around the managed development and management of clinical programs, that our needs for information, in fact, will converge. But I think the ability to develop separate reports and disaggregate data are going to be necessary, and we would figure for a period of time on being able to provide specific reports to specific sets of users, and that's what we are building.
All right, this may be the last question. Three parts to it. Where do you see yourselves in 1 year, 3 year, and 5 years?
Wow. In 5 years, retired, perhaps.
Right. Personal question.
But I do see this as an evolving system, and whereas right now there are, in fact, different funding streams supporting each piece of it, I anticipate that in a year's time, certainly around specific diseases like severe mental illness, we'll start to see them those funding streams coalesce around populations of patients and integrated programs be developed along those lines. In 3 years, I think that that will extend beyond severe mental illness to include really the broader range of vulnerable patients. I would expect that we will be developing new relationships with partners throughout the borough of Brooklyn and really spread our geographic reach and the depth of our programs. And over 5 years, my crystal ball is kind of cloudy.
All right. Well, I especially want to thank you all for joining us, and especially thank David and Karen and Madeline and Mike for their partnership. It's a treasure to be able to be on the ground in such an innovative and important program. So we're grateful. We will be following up with the audience questions that we couldn't cover today, and we'll be hosting a recording of the webinar on our website, and we'll also be sending out the recording to the participants today because we know there was a little bit of trouble getting in, and so we'll send that out to you directly. Thank you very much. Have a good day.